Adiza, Utuminjina Adiza, Yabutarma Mobiba, Namuodoma Umi baby, my Yana no man want to get us Mirabe, my enchumbo. I promise to deliver, girl I'm not to deceiver, together forever, no retreat, no surrender. I promise to deliver, Adiza the receiver, until I take no surrender. Me I know woman, me I see woman, but I don't see your type before. Girl, you are so decent, so this weekend I want to see your dad and mom. Girl, I love you plenty, plenty. You make a follow Humpty Dumpty. Yeah, me I go from Batimato. And for you alone, I dey go for loan. It's baby no no, baby no no. Medinchi na baby no no no. It's be a pono no, be a pono no. Oda minje ya minje tuntumano. Oh bidaba, oda me no ba okonoba. My baby mama, my sugar. Now because of you, I promise to deliver. Girl, I know to deceiver. Together forever, no retreat, no surrender. I promise to deliver. Adiza the receiver. Until I take with that. No surrender.
Chawale nyimbencha nkirufa bebrese wan fame chimpo anka mejula ne wo cause most my sugar wo sisu ne raba ma menka wunim se me bibia ne wo okemi akashi mo baye mi se ke come on you can feel me ni jimi neke manso le moi me kuku gadao fia mojila wo ma yi ma babia o we na nam du jolo ye no woni ma du jolo na ma kwe ma kona du jolo we na nam du jolo yeta ma kwalo Sonia ma wusi owode what if she afinele na she do na bana mi ante anoni forever ayo
baby no no medinchi na baby wodo kono no be a pono no oda minje ya minje tuntumano oh bidaba oda me no ba kono ba my baby mama my sugar now because of you I promise to deliver.
Girl, you don't get any issue. Then I go hold you well, and I will do anything that you wish. Me share my love, so don't pay me for it. No one hears that tomorrow, somebody else come take you for it. They do me no more. This thing no be normal. Me no want to do more. Please don't give me trouble. You get do me no more. This thing no be normal. It go be my lover.
Pick you up in the 40, bring it on what is on your mind. You're being to say Bonnie and Clyde, and all that you promised to show and tell me no time was soon when I'm right here. You and I together, so we go together. See me pose no abiana, we pose here fly me say nah. Life in with you, girl, me love it. Dying with you, tell him forever. Will I live? Who is that me say nah. Diamond rings in your body, darling, come find me.
Oh, you did do me lomo. This thing no be normal. Me no want to do more. Please don't give me trouble. You did do me lomo. This thing no be normal. It go be my lover. You really be like bad. 0244, my baby, I just want to call your number. I find my person who will take my pain away. I give up for love. I don't want to be so jealous. If you leave me, baby, chaos. This tries up, you too fine, oh girl, I want you for you. Something nice, oh, I don't mind, oh. Me, I will, yummy, oh. Me, share my boss, so don't let me for you. I know is it tomorrow, somebody else come take you for you. They do me lomo. This thing no be normal. You don't want to do more. Please don't give me trouble. You they do me lomo. This thing no be normal. You go be my lover. You really be like power. na ba yasido. Nang committed peka, you coming got me a coming ba. Pressure kwana me daminda. Me didn't na ba yasido. They spit on my face, so they block our way, so yo.
Me did the young antechua, and maybe I'm discovered for Europe. I come a bush and for Ghana. No, me used to tap send, tap send. No fee mobile money transfer. Eye easy, eye convenient, eye fast, and sounds so free. Won't you share? Me discover ye map him. Tap send. NTN. Also download the Tap Send app. No, ever mobile phone so free. Na first ka come a bush and for Ghana for na. Tap send. Papa no.
Property Investor Africa connects investors, buyers, sellers, and partners across Africa to you creating trusted opportunities in property investment.
Welcome to Property Investor Africa, your gateway to Africa's real estate revolution. Whether you're a developer or seller of prime real estate in Africa, whether you're an investor or buyer hunting for opportunities, or you're a supplier of real estate products or provider of services in the real estate industry in Africa, this is your marketplace.
Hello, sorry, apologies. I am down with the flu. Hello, and good evening, everybody, and welcome to the OT Health Talk Show. My name is Abina, and together with my co-host, Dr. Akos, give us a wave. We are the Oasis. Dr. Akos, I think you're going to have to do the introduction because I'm struggling a little bit.
Well, I think we're both unwell today, so we're going to try our best, but beg your pardon. Right. Yeah, I think it's just, are you okay? Oh, bless her. Okay. Well, okay, welcome to the show, everybody. Thank you for coming and being on time as per usual. The people who are always on time are always on time, so it's nice to see you all. Today we've got a really interesting topic. We're going to talk about diabetes, its complications, and sort of prevention and all other things to do with diabetes. But just before I introduce our host, I just want to do the normal introduction to say, obviously, Abner has already introduced us. But also want to say thank you to our sponsors, Taptap Send, OT Media. And if you're on the live streams, YouTube and Facebook, welcome as well. And we'll be looking at questions from both places. As you know how the show goes, usually we'll have the presentation and then we'll have the Q&A session. So please do listen. It's really an interesting topic today. And again, you can ask any questions, not just about the topic today, but like I say, this is the only show where your host is also a doctor. So if you've got any other questions regarding your health that doesn't not necessarily pertain to what we're talking about today, feel free to ask that as well when it comes to the Q&A sessions. Amina, are you okay?
Yeah, just a few breathing difficulties, but nothing much.
Okay, well... Okay. Speedy recovery. But yeah, so we've got Sunjay on. I can see he's on. I just can't see his video yet. So there he is.
Hello.
So Sunjay is one of my favorite doctors that I've ever met in my life. And he's just genuinely such a nice person. He was my senior when I was working in the hospital, and he is a specialist registrar in sort of diabetes and endocrine. So he's going to talk to us about that today. But yeah, I'll leave you to talk a little bit about yourself, Sunjay. Tell us a little bit about who you are, what you do. We see that you've got your dog on next to you on the flyer as well. Maybe you want to talk about your associate professor a little bit as well.
Absolutely. Yeah, thank you, Akos. So I'm Sunjay. I'm a very simple diabetes and endocrine registrar. I like to treat people more from the patient perspective. I've always done that, and I think it's usually better that way if ideas always come from the patient rather than the doctor just telling you what to do. I think we live in a health environment now, especially in the UK, where it's sometimes difficult to get access to healthcare, and often people don't have time to spend with their patients. So I think it's important that more the patients know about their health and more things they can act on their health, then really the better they can do for themselves as well. So that's what I'm hoping to do for you guys today.
Yeah, Aspire, that all sounds very good. So yeah, right from here, we're just going to dive straight in. I've allowed you to share your screen, so if you've got any slides,
let's have a little look.
please go ahead.
Just load up the screen. Just let me know when you can see it.
It's loading. There, got it. So yeah, crack on.
You can see it, yeah, perfect. So yeah, like I said, I'm Sunjay. I'm one of the registrars in diabetes and endocrinology. What I want to talk about today is mainly concentrating on type 2 diabetes. One of the key messages is the epidemiology. I have exactly the right crowd of people that I want to talk about the epidemiology of type 2 diabetes. Also, we can talk a little bit about the complications that I worry about in clinic and in my patients. And I also want to go beyond blood sugar. Everyone always associates diabetes with sugar, rightly so. But actually, there's a lot more that causes problems in diabetes. And there's a lot more we can do outside of just blood sugar or sugar levels that can help improve patient outcomes. So really, these are just some of the aims that we're going to go through. And of course, if there's any questions that you guys have, we can go through that at the end. It's not a problem whatsoever. So starting with, first of all, the epidemiology of type 2 diabetes in West Africa. And this is what I was saying about having exactly the right crowd, because at the moment, the worldwide trends, the IDF data suggests that West Africa and Africa in general has an increase in the prevalence of diabetes. We saw this sort of pattern happen in Asian countries where there's a lot more urbanization. There's a lot more Western diets now filtrating into the populations, and lifestyles are starting to shift. As a result, we're seeing increased numbers of diabetes, but also the complications of diabetes, not just in older patients, but also increase in diabetes within pregnancy as well. So it is affecting the younger population as well. Now, here's quite a busy graph, but this was the IDF data from 2024 about diabetes generally in Africa. The reason I don't actually like these in general is because, well, for me, my family is from Tanzania, and the populations in different African countries are totally different. I think it's really unfair to just put it as a whole continent and say this is the prevalence of diabetes in Africa. I'm sure the crowd knows here that in different parts of Africa, there's different diets, different lifestyles, and certainly, therefore, the populations are different. But unfortunately, in the big wide world, Africa seems to be grouped into one. But what I want to point out is a few hotspot areas. So the areas of the map in Africa you see in dark red is actually higher prevalence, meaning that the amount of diabetes they're seeing in patients aged 20 to 79 is actually increasing. But what's more worrying in terms of if we just use Africa as a whole is it's the highest predicted region of diabetes anywhere in the world. So at the moment, they think it's around about 25 million. They expect that to more than double, easily more than double. And if you look here at the bottom, at the top 5 countries, you'll see actually Nigeria is top with the current prevalence, and that will easily double by 2050. And as you can see from where my family is from, we're no better either. In fact, we're probably going to overtake you in Nigeria anyway. So, and that probably has already happened. And the interesting thing there is, like I said, they group together Africa as a continent, and 4 in 5 adults with diabetes currently in Africa are not diagnosed, which is the highest anywhere in the world as well. So these numbers are probably underestimated. And on top of that, Africa as a continent has the lowest expenditure in terms of diabetes anywhere in the world as well. And the last point there is actually, yes, 1 in 7 live births are actually affected by high sugars in pregnancy. So it is affecting younger patients as well. Don't just think that this is something that only happens to our uncles, aunts, and grandmas. This is happening in populations aged 20 and above. So this is affecting young people as well as older people as well. So as you can see, this is an ongoing problem. I certainly will be in a job for a very long time, so that's good news for me. Certainly, if I want to open up a private clinic, I will be heading towards Africa and make lots of money, so that's good. But the problem we're having is also the education and the access to different parts of Africa as well in terms of healthcare. So there will be certain regions which will be worse off than other regions rather than just a standardized problem. Now, there are contributing factors. We saw this influence happen in Asian countries where traditional diets and lifestyles were changing depending on Western culture and Western diets and Western foods. And obviously, we also saw the socioeconomic conditions changing across Asian countries, and we'll probably see the same in African countries as well. So this is only a problem that's going to get worse. And if the problem gets worse, your health economy also takes a hit because complications cost a lot of money. And the more complex your case, the more health, money, or economics is going to be impacted by diabetes. So the reason why it occurs is this big thing which you read online. It's a very popular thing in endocrinology and diabetes at the moment. It's called insulin resistance. And essentially what happens normally is you break down your sugars into glucose, and this is absorbed by all of your cells in your body. And this is, imagine your petrol, your diesel. This is what your body uses for energy and to carry out its day-to-day tasks. And insulin is regulated by your pancreas, and if it finds that your body detects your glucose is high in your blood, it then releases more insulin, and that glucose moves into your cells, maintaining a nice balance. Similarly, if your glucose is low, then your insulin effectively lowers or turns off, allowing you to maintain a nice balance in your blood. The problem you get is when you get a disruption of that, particularly with your pancreas, and your pancreas is working as hard as it can, and it's just being disrupted all the time with very, very high sugar load, it can overwhelm it. And eventually your body becomes resistant to insulin. So you now require more insulin on a day-to-day basis to try and get that glucose, extra glucose, into your cells, and eventually your pancreas can tire. When you get sort of your pancreas then sort of giving up and failing to regulate this is what causes, or what we see when we then prick the finger, check your blood, and we find that your blood has lots and lots of sugar in it, thus giving you diabetes. And this is because your cells become less responsive to the insulin, so they're just used to so much insulin being around because of your high sugar that it eventually becomes resistant on your cells. We know that in other conditions such as obesity as well as diabetes, it causes a lot of inflammation in your body. It causes, with the inflammation, causes problems with the signaling of the pathways, and that sort of communication between your body, your insulin, and your sugar, it also gets affected. And that is influenced, like I said, by other conditions such as obesity, but there are some genetics as well. We do know some populations, for example, can get diabetes much earlier ages. We also know that, for example, if you have a white American, for example, their obesity levels may be BMI over 30. However, if I had a Chinese person in front of me today, a BMI of 21 is regarded as obese in China. So genetics also play a part, as well as your environment as well. So the risk factors of developing this resistance can come from a lack of physical activity, which contributes to the development of insulin resistance, and of course obesity as well, which doesn't add a great mix. And we talked about the inflammation that can cause. And then the diet's changing. So especially diets rich in carbohydrates, processed foods, fast foods, can start increasing those problems of insulin resistance and diabetes. And as we mentioned, the genetic factors, they're already there. So if you are now changing your diet and your lifestyle and you're already predispositioned to have a higher genetic risk, you're only asking for trouble. And as we mentioned, with the urbanization impact we saw in Asia, which we will see and are seeing in areas of Africa, those changes create the perfect storm and create a lot of work for people like me. So the initial symptoms of diabetes can be quite generic. The most popular ones we see in clinic are patients coming in reporting that they're very, very thirsty, drinking way more water, never feeling sort of satisfied. And at the same time, then weeing quite a lot, so frequent urination, particularly even throughout the night. And they'll even report that they're drinking pints and pints of water throughout the night as well. We sometimes see people with lethargy and fatigue. Other patients can have unexplained weight loss. Blurred vision is another one, where even if they go to the optometrist to get their glasses done and somebody looks in the back of their eye, they notice changes in the back of the eye which can be associated with diabetes, which we'll have a little look at later on this presentation. And also some people can come in with slow healing cuts and sores. That one I see a little bit rarer. I think your diabetes has to go pretty far for those sort of things to be happening, but they are a symptom of diabetes nevertheless. So I'm going to go through some of the complications that we see in type 2 diabetes, and I want you guys to stop thinking about pure sugar. And as the talk goes on, sugar gets less and less important. We're done with the sugar in this talk. Okay? So the complications we see, they're usually categorized into main two bits, is microvascular and macrovascular. Now, microvascular complications include damage to very small vessels, vessels such as in the back of your eye, within your kidneys, and around your body, especially in your fingers, in your toes, in your feet, in your hands. And they can cause retinopathy, nephropathy, and neuropathy, which we'll go through later in this presentation. It can also cause complications in what we call the macrovascular, your bigger blood vessels. And this can lead to quite serious problems such as heart disease, heart attacks, heart failure, stroke, which can be life-changing or even can result in death, and things like peripheral artery disease, where you have a problem with the flow of blood, for example, to your legs. So when you start walking or exert yourself, you get really bad pains in the back of your calves. And what we want to do is get early detection of diabetes, manage this aggressively to reduce the burden of the complications. Okay, you may not reduce the burden of diabetes, but if you can reduce the complications, that would be the key thing in improving people's health. Because if you think about it, nobody ever comes in and says, oh, my sugar's 9 or 10 today, I feel really unwell. But if somebody comes in and says, well, actually, my vision's gone very blurry, I can no longer drive, I can no longer work, that's causing a bigger impact on their quality of life compared to what they actually see on the blood sugar monitor. The only times you really feel symptoms drastically on your blood sugar is if they become low, which they really shouldn't in diabetes unless you're giving very aggressive treatment. So microvascular, like we talked about, is damage in your eye, and it causes damage to the small vessels in the back of your eye. This is why sometimes when you go to the optician, they take a picture of the back of your eye to have a look at these blood vessels. And what it can lead to is damage in these vessels can then change the vision in your eye as well. This also happens in your kidneys, where you have a very, very complex microvascular structure. And again, damage to this can impair the function of your kidneys. And prolonged sugar around the small vessels on your nerves can also cause nerve damage, leading to pins and needles in your feet, in your toes, in your hands, and also loss of sensation as well. That in itself can then cause problems such as ulcers in your feet, which again with diabetes can cause them to not heal very well and can cause further problems such as infections. So really, we want early diagnosis to prevent these disabilities from occurring in patients and allow them to sort of have a good quality of life. So this is what the back of your eye looks like. This is what your optometrist sometimes takes a picture of your back of your eye. And what they're looking for is any damage damage to the blood vessels. Sometimes they may see small swellings. Sometimes they may see new blood vessels being formed because your current ones are currently blocked or getting narrower. And so when you create more blood vessels, you have a chance of problems like bleeding in your eye, which could then lead to scar tissue and also can lead to quite serious problems such as vision loss with retinal detachment, or a blurring of your vision, which causes your vision to deteriorate over time. Same with your kidneys. You have a lot of blood vessels within your kidneys. I want you to imagine your kidney as a sieve. And when you wash your vegetables in your sieve, your vegetables stay nice and within the sieve, and the water takes out all the bad stuff. Okay? But when you have damage in your kidney, imagine the sieve and the holes get a lot bigger. So what starts to happen is actually with damage to the holes and they're a lot bigger, you start losing some of the good things that you want to keep in your body, such as proteins. So one of the things we do for patients with diabetes is we regularly measure how much protein is leaking out of their urine. And if it starts going higher, we know there's damage happening to their kidneys. And another problem which I mentioned was neuropathy, which is damage to your nerves. And this can cause problems with muscle weakness, particularly in your hands, arms, and legs. It can cause tingling, burning, pain, or cramping sensations, numbness, feeling very cold in your feet. And it can also cause sores and calluses, which can lead to infection and ulcers as well. And we talked about the macrovascular. These are the most serious, this is not just something that you can just sort of live with and get over. These can result in very serious heart attacks, very serious strokes as well, and can be life-changing or life-ending, as it were. So how do we go about reducing these problems? Now, everyone focuses on sugar. So I'm from an Indian household, okay? So what we have is whenever we have family get-togethers, we always have 2 pots of tea. And we jokingly, it runs in my family so much that we call it the diabetic tea and the normal tea. And the diabetic tea basically has no sugar in it. And the normal tea has quite a bit of sugar, as we do like sugar with our tea, okay? But what tends to happen is when everyone serves their tea, nobody asks the diabetes patients, would you want to hold off your carbohydrates? So with their tea, they're still having biscuits, they're still having deep fried food. Most of our food in Indian culture is deep fried. And to be honest with you, that's actually what's causing the main problem in diabetes. So the practical method should actually be limiting high carbohydrate food. It's not necessarily a sugar cube in your tea. It's more what you're eating with the tea. And so what we need to be thinking about is practical medicine, reducing carbohydrate intake. Now, people will say to me, well, if I reduce my carbohydrates, I'm a lot more hungrier, which is a fair point. So what we need to do instead on that diet is increase protein consumption. If you increase your protein, overall, you will feel full just as much as you would if you ate as much carbohydrate. The difference being is that it wouldn't spike your blood sugars as much. And we're going to look a little bit later in terms of GI index and how that affects your blood sugars as well. And generally, if you even just take this one simple rule away of reducing your carbohydrate intake and increasing your protein, you will already either prevent diabetes from occurring or certainly reduce your risk of it occurring. And if you already have diabetes, this will automatically straight away start improving your blood sugar levels from the get-go. So this is a schematic showing exactly what I've just been saying there. So the common misconception amongst diabetes patients is, I can't eat fruit because if I eat fruit is sugar and sugar is not good for me, therefore I have to avoid it. Well, actually, if you look at this schematic here, say this person with diabetes eats this banana there where there's 17 grams of carbohydrates and the carbohydrates are broken down into glucose. Your glucose then enters your bloodstream, okay? And this is what we measure when people prick their fingers and we see how much sugar is in their blood. But actually, if they avoided the banana and had a slice of naan bread instead, this has 43 grams of carbohydrates. The carbohydrates in your body are broken down eventually into simple sugars, into glucose. and that then enters your bloodstream. And as you can see, even from this schematic, there is a lot more glucose in your bloodstream because of a carbohydrate such as the naan bread compared to the banana. So this whole myth that, oh, I can't have this fruit, I can't eat this orange, I can't eat this grape because I've got diabetes, but I'll have about 3 naan breads, is completely false. It's the naan bread that's actually causing the problems. It's the carbohydrate that's causing the problems, not the simple fruit. That's not to say you should gorge down 5 bananas, but what we should be thinking about is actually, is there an alternative that we can use for snacking or for eating to help prevent this spike in your blood sugars? So this is what we talk about when we think about carbohydrates, and I try to include some foods that are popular in the West African diet as well. And just like the West African diet, Indian diet as well is very high in carbohydrates. And so I would never say to any Indian, and I would never say to any West African, please stop carbohydrates, full stop. It's impossible. It's a very good staple food part of the diet. And in any diet, you need a balanced diet, okay? So what I would say to patients is look at the plate in front of you. Let's say on that plate you have a bit of cassava and you have a little bit of vegetables, and you may have a little bit of chicken as well. So your chicken or your fish would represent your protein. Your carbohydrate would be your cassava, and on the side you will have your vegetables. But what I would say to patients is half the cassava that's on your plate and increase the protein, increase the chicken or increase the fish on that plate. Therefore, you are still eating the same amount, you are still feeling full and satisfied from your meal, but your blood sugars will be a lot less. And moreover, you'll feel full for longer, so you will not be tempted as much to snack as well. If you made this one simple change in patients with diabetes, or even to try and prevent diabetes, let's say you've got a really strong family history of diabetes and you're very high risk, this simple change may actually buy you quite a bit of time as a result. And this is what we talk about when it comes to high GI and low GI foods. So if anyone gets time a little bit later, just pop it into Google, stick it on top of your fridge. You'll have foods such as your chips, your biscuits, your cakes. Remember, these are the foods that the diabetes patients are having with their sugar-free tea, which actually spike your blood glucose in the first hour or so. Whereas if you have things like vegetables, lentils, even whole grain bread rather than white bread, you notice the spike in your blood sugar in the first hour is a lot less. And actually, it continues at the same level at hour number 2, if not a little bit higher, but it continues the same level as those previous foods as well. So it's all about portion control, maintaining an overall healthy diet. So that includes having a little bit of fat in your diet, having good amounts of protein, halving the carbohydrates, and also increasing the fiber in your diet as well. And it's everything in a balance. No one's saying to starve yourself. No one's telling you to stop eating completely. It's more about choosing the right things or substituting things to make the plate of food in front of you a little bit more healthier. Now, here's a little table. I don't mind if you guys want to take a picture of this, or there's plenty online which shows you how you can substitute foods from a high GI index in the red to even orange and green. So, for example, even if you just take bread, if you just had white bread in your toast in the morning, but actually you said to yourself, you know what, I'm going to change it up a little bit, and I'm going to move on to either rye bread, wholemeal bread, or even sort of sourdough or wheat or brown bread. You'll move yourself away from the high GI index food over to the medium and the low GI index. And this already, especially if you already have diabetes, will make a big difference to your blood sugars. And again, if you're preventing diabetes, again, moving over from instant white rice over to even basmati rice or brown rice will again help those blood sugars when they are spiking whilst you're having those types of foods. So there are changes you can make. It's not about giving things up. It's more about substituting little things on your plate, not changing your whole diet, but certainly making some meals a bit healthier if you can. Now, this is a little bit about what I actually do in clinic. And when I see my patients, the first thing I'm talking about to them is diet and lifestyle. So I'm asking them about their current weight, if they've gained weight, what their previous weights were before diabetes, and also how active they are in their lifestyle, because this already makes a big difference to diabetes. And I'm going to show you a trial a little bit later on that proves my point. The second thing is smoking. If you know a person with diabetes has those complications we mentioned, such as heart and strokes and problems with their eyes and their kidneys and their nerves, smoking will also make those worse. So it's always a good idea to ask your patients about smoking and really to avoid smoking. If they have to vape or use nicotine patches, that's absolutely better than smoking. The next thing I talk about with my patients is their blood pressure. How many of you have ever seen a relative with diabetes? Has anyone ever asked that relative, is your blood pressure controlled? If we know that you have problems with your blood vessels, why are we not controlling your blood pressure? In the same way, has anybody asked their relatives with diabetes, has anybody checked your cholesterol? Because these all reduce heart attacks and strokes in any patient, let alone a patient with diabetes. And then we also look at and monitor for complications. Again, think about anyone you've seen with diabetes. Have you ever asked them? Has anyone taken a picture of the back of your eye? Has anyone checked your kidneys to check if you're losing any protein and look at your kidney function? Do they examine their feet regularly to make sure there's no ulcers and there's no cuts or bruises that they can't feel? And finally, the last two things I do in my clinic, believe it or not, is then turn over to medications and their glucose control. And that's looking at what type of medications they're on to prevent complications, but at the same time looking at things like their insulins, their metformins, and their tablets, just check if they've got good medications, not just to keep their sugars at a good control, but also to prevent complications as well. A lot of these medications in diabetes also help prevent problems, things like heart failure, good blood pressure management, and also kidney disease as well. Now, this trial, it was a very cruel trial. This was actually done in the UK, believe it or not. So this is a very famous trial. You can go and read about it a little bit later if you have any time. It's called the DIRECT trial. And essentially, it tried to have some aims of remitting diabetes. So this is for everyone who's in that pre-diabetes range, in the diabetes range, newly diagnosed diabetes. And the question is, can you turn off the diabetes? Can you get rid of it? Can you go backwards? So what the program did is they made participants go onto a low-calorie diet. This was very cruel. They made them take only 800 calories per day. So, you could imagine how many grumpy people you had in this trial. And what they noticed is that as people were getting on with this diet, they lost a lot of weight, around about 10 to 15 kilograms for some individuals they actually lost in this trial. And then slowly, normal foods that they were eating in day-to-day life, with the aid of a dietitian to try and choose healthier choices, was then reintroduced. And they were supported by their GPs, and everything was done at home. This was not done in a hospital. This was not done in a fancy clinic. This was all done in their day-to-day routine at home. And what they found is nearly half of the trial participants achieved remission of diabetes in 1 year. Remission meaning that if I went and poked their finger and took a sample of blood, their blood sugar levels were normal. And what was also really interesting is that after 5 years, those that kept up most of their diets and also kept their weight pretty stable and didn't gain a lot of weight managed to maintain that remission. Meaning, again, their blood sugar levels were completely normal and they were not on any medication for diabetes. What we also found is those people who didn't achieve remission completely, but actually did follow the diet, had also improved their diabetes health, and they suffered fewer diabetes complications compared to people who were not on the trial and were just living their normal daily lives and not making any changes to their diets and lifestyles. So what we found is significant weight loss soon after you've been diagnosed can actually lead to remission for many people with type 2 diabetes. And like I said, remission means that your blood sugar returns to levels where you were not diabetic before without the need for any medication for diabetes. And we found that early intervention and lifestyle changes are the most crucial, effective management for achieving this remission in diabetes and, of course, reducing the complications we talked about earlier. And the reason we found that is because what happens in type 2 diabetes is there's too much internal fat around your organs. So just like Indian people and Asian people in Africa, you will have people who are thinner, but actually they can get diabetes, and especially at a younger age. And what we find is that internally, what we can't see, around their organs, they have a lot of fat. And this actually causes a problem with their insulin to function in their body. What we did find on this trial is when you lose weight, you lose some of that internal fat, what we call visceral fat, and it helps the insulin to be produced and work effectively better. And once that function is better, that's what allows the process of the diabetes to almost be turned off, leading to a remission. And so that's why it's important we spread this message, because in West Africa, similar to Asian populations, diabetes can develop at a younger age and a lower body weight due to this visceral fat. So even small reductions in our populations can reduce this resistance of insulin and actually prevent any complications in the future. So this was a very important trial in trying to establish that, and certainly it's been accepted pretty much worldwide that findings from this has now encouraged people to use the weight loss medications that is very popular in the popular culture for this very reason. And this is how it first came to light using this trial. So that was just a quick whistle tour of diabetes complications and how we can start acting early in day-to-day life. We don't need any fancy diabetes doctors or anything like that. If you just use some of these key messages in your day-to-day life, you will improve your health. You will prevent the risk of diabetes. Of course, risk is never absolute, but you certainly reduce the risk of diabetes, and also, as a result, reduce the risk of complications as well. And that requires holistic care. This is not just about how much sugar you're having in your tea. This is looking at your carbohydrates, is looking at your blood pressure, looking at your cholesterol, looking at your smoking, looking at the back of your eye, looking at your kidneys, checking your feet, and making sure that if you do have any relatives with diabetes, don't just be focused on their sugar. Think about asking these other questions, because maybe someone out there is not asking them those questions, and that's why they're not being looked into. Everyone just concentrates on the one thing, which is what's your blood sugar, what's your HbA1c, and that's it. But actually, we need to start thinking about all these things to try and reduce complications. And that's all I have really to shout at you guys for. But if there's any questions, then please feel free to go ahead.
Wow. Yeah, go for it.
No, I was just going to say, definitely there'll be some questions. We'll have a Q&A session, but I've definitely learned a lot myself. Pizza is green. I was feeling...
I knew, like, don't dwell on that.
I had pizza earlier on, and I was feeling a bit downcast coming into this, but to see pizza in green...
Yeah.
He didn't...
The thing is, this is the thing. There are some days, right? You're never going to be perfect 100%. There are some days, I'm a diabetes doctor. If someone said to me, I really want some cake today, I'm having a bad day, get the cake. It's not a problem, okay? Some of my diabetes patients say, some days I just need a cheat day. That's absolutely fine. I think the key message is that you're understanding where the problems are coming from. And I think a lot of people don't really, especially in diabetes, they just think about sugar. No one actually talks about anything else around it. So, of course, even in my patients, I encourage cheat days. It's good for your mental health and your quality of life, and that's fair enough.
Right, okay. Before we do the Q&A session, we're going to go into, we're going to have a quick advert, but like I always say, guys, think about your questions, because we've got Sunjay, the specialist here today, so you really want to go and ask him everything you want to know about it. He's not a nutritionist though, so don't ask him about food and things. Okay, he can't tell you what to eat. But yeah, so after the break, we'll come back with a Q&A.
So physical money and but me do right to say. For me send you in a minute in Sabakandia and then one Taptap Send.
Yeah, ebusiafo bidin di na nakoma pachirewa 1. They recommended Taptap Send amamo. And that's for aba. O send ko fa baby a. Na ye basa. Our rating so ye. Omo ye A1. Nti obian load do tap send. That all says sika for tap.
Yɛbɔ de wɔkyerɛ amansan yɛbɔ de wɔkyerɛ Ghana for say yɛwɔ akwantu ne yɛde sika kɔfie nie me yɛn fɛnfa baabi a yɛbɛnu yɛn ho tap ɛdɛmu fuwa tap send in this street
The tap de no ana ɛkɔ. Tap de ɛno na yɛ nyinaa ɛyi.
Piao.
Property Investor Africa connects investors, buyers, sellers, and partners across Africa to you creating trusted opportunities in property investment.
Welcome to Property Investor Africa, your gateway to Africa's real estate revolution. Whether you're a developer or seller of prime real estate in Africa, whether you're an investor or buyer hunting for opportunities, or you're a supplier of real estate products or provider of services in the real estate industry in Africa, this is your marketplace.
Okay, welcome back. So this is the Q&A session, and I've been buzzing to ask this question from the beginning, so I'm just going to go straight in and start with my question.
Go for it.
Because I know somebody personally who says this, right? And they say that basically whenever they have something bad, like something from the red list, so something like white bread, and they will say they're just going to add spinach or broccoli or a bit of rocket to it, or you know what I'm talking about. So they have the white bread, and they were like, yeah, but I'm having it with spinach, and I'm having it with rocket, and that should be okay. What are your thoughts, or what is your advice? That, I mean, number one, does that work? Does that help with the lessening of the effects of the white bread, just because they're having a bit of vegetable with it?
So not really, no, because your carbohydrates are measured in grams. Right. So if you think about that piece of white bread, let's say, for example, just throwing out numbers, you have 100 grams of white bread. Mm-hmm. And now you're going to put your spinach and your healthy vegetables on top. When you eat that plate of food, you're still having 100 grams of white bread of carbohydrate, which will spike your sugars. What would make the biggest difference, like you said, is either changing the bread or just halving the amount of bread you have. So if you're on that plate and you think, no, I have to have white bread. I've had it since I was a child. I can't have any other type of bread. Everything else tastes like cardboard. Then actually what you need to think about is I'll have 50 grams of the white bread, but I'll increase my protein. I'll have some maybe cured meats on the top and have a more balanced meal with the spinach and the vegetables. So what that would do is make a difference. And you'll still feel full because you're replacing what you've lost in carbohydrates with that protein. And notice I didn't say go to 0 grams carbohydrate, because you still need to have a balanced meal. And you still need blood sugar to work in terms of your body. So what you can do there is actually replace the carbohydrate by half of it and increasing protein instead.
Okay. And just to follow on from that, if somebody was then saying, okay, you know how fruits have natural sugars in them, so things like grapes, right? And again, I know people who would say, I don't eat grapes in the morning, or I don't eat it last thing at night because I feel like it's going to spike my sugars. Again, what are your thoughts on that? Does it matter what time you have these fruits that are high in sugar?
So with fruits, you're talking about sort of natural sugars.
Yeah.
And natural sugars are sometimes unavoidable in foods and drinks. But what I would say for natural sugars is that, yes, they will spike your sugars a little bit. That's without a doubt. But they will also burn off quite quickly. So the reason being is they're more simple sugars or simple carbohydrates. And so what I always say to patients is the other good thing with fruits especially is the fiber content. So they should still be a part of your balanced meal. I think usually timing doesn't really matter because the reason I say that is people have different lifestyles. If you're a shift worker, for example, there may be some evenings where you do need that banana and you do need that apple whilst you're on your shift, or if you've got some activity that you're doing in the night, or if you're doing some work, then those things can apply, and it doesn't mean that you have to avoid it, as it were.
Last one, Abna, I promise, before you come in. And then, so would you say it's better to actually eat like your grapes for breakfast than to eat your white bread.
Yeah, 100%. But like I showed you on that little schematic with the banana and the naan, so it's not a replacement. So if you remember from that naan, I think it was about 43 grams of sugar that eventually, led to sugar in your blood, whereas the banana was only 17 grams of carbs. But if you had 5 bananas, that would probably be the equivalent to that one naan. So it's, again, you can have the grapes in the morning, but again, it's more moderation. It's more about thinking about the balance of the plate of food you've got in front of you, rather than just solely having grapes on its own. The other problem is, of course, if you just have the grapes on its own, in about an hour and a half, 2 hours later, you're going to be hungry and you're going to want a snack. So you've undid any good work that you've done. What you want is more complex GI carbohydrates, proteins, fats, fiber. So when it even comes, if you have your breakfast at 8 a.m., by even 11 a.m., you're still actually quite full and you're not feeling hungry and wanting to snack. And maybe you can then wait till 1 p.m. to have your lunch.
Okay. Thanks for answering my questions.
No worries.
So yeah, I've got a few questions, but I think mine is more about living with diabetes and like the
of course
patient aspect. So it's like I think one of the myths, well, not a myth, but we certainly believe, a lot of us believe that when you have diabetes, it's forever. So is it reversible, or is it like you're going to be on medication for the rest of your life?
Yeah, that exactly. You've hit the nail on the head there. That's exactly what the belief was, even in medicine. Okay, and I'm pretty sure if you walk into half of your GP practices today and say, I've got type 2 diabetes, they'll tell you it's forever. They'll call it a chronic condition. So don't just think it's the population who feels that. There's healthcare professionals out there who don't know anything about the direct trial. And that's why I thought I'd bring that to you guys today, because it does show that if we treat it early and treat it aggressive early, then yes, you can push the type 2 diabetes in remission. Now, what I would say is almost think of that as a warning shot, that actually, oh my God, I was pre-diabetic or diabetic and I managed to reverse it. That doesn't mean that it can't come back. What it showed in those participants is when they went back to their lifestyles and they gained weight again, the diabetes came back with it. So certainly what I would say is, I wouldn't say it's cured, but I would say it's in remission. And it's controlled by your own diet and your lifestyle, rather than, yes, we're going to put you on medications, 3 or 4 of them, and insulin and injections and things like that. There will come a point when your pancreas gets too tired and what we call it atrophies and the cells get damaged. At that point, yes, it's very hard to reverse or remit diabetes, and that's because there's just too much damage. But at that point, your sugars will be very, very high, and you'll probably have it for very many, many months and years of constantly having high sugars, and as a result, your pancreas essentially, in a way, almost fails to operate in the most normal way it can. So I would say, certainly, in answer to your question, early detection of diabetes and early aggressive management in terms of lifestyle, diet, sometimes even with medications. You're going to see it now with the new NICE guidelines that will come out in the UK, that if you're under the age of 40 and you get diagnosed with diabetes, they will put you straight on medication to try and reverse it. But also they will offer you the weight loss medications to try and reverse it. That's only just come out this week. So they are now catching up. Medicine is catching up and realizing if we treat this early, we can push it back into the normal range, and then patients can manage and maintain it.
Well, yeah. But I think the unfortunate thing there is that obviously Africa still needs a bit of catching up to do. We probably couldn't afford to offer the weight loss.
Yeah,
that was the first line.
Absolutely. I think in terms of, and this is what we saw in the Asian populations as well. I think forget even the weight loss medications. I think even getting to a healthcare professional early enough will be the challenge in places like Africa, as it is to this day in India and Pakistan and Bangladesh. The problem is they will only go and see a healthcare professional when one of those complications, such as the eyes, such as the ulcers, something will happen that will change their quality of life. They will go to see a doctor and the doctor will say, my God, you are literally peeing out sugar. And it's sometimes at that point too late. So while we have, if there's any people here from the UK or there's relatives and you've got a high risk of diabetes running through your family, I know, for example, in my family, we have a running joke that everyone's going to get it, we're all going to get it. right? Grandma's got it, auntie's got it, so where next? It's those kind of patients that we're like, well, if you know you're at high risk, start making some changes now and look out for any of these problems that you might get in the future. And if you do get them, we can treat them aggressively and early and reverse it.
No, thank you guys. One more question, and then I've seen a question in the chat, so we'll go for that one. So I mean, where we both come from, Asia, Africa, we do delve and believe in herbal treatments for a lot of things. So just wondering, do herbal remedies or natural treatments actually work for diabetes? Are they effective?
So there are some herbal remedies that will reduce your blood sugars. Certainly gourd. I don't know if you've heard of gourd, and this is becoming a very hot topic. So gourd is bitter gourd is like a type of vegetable that you can get, and it's actually got some what we call sulfonylurea effects. So glycoside is a sulfonylurea, it's a type of diabetes medication. So if you were to glug a jug full of gourd, bitter gourd, you would probably reduce your blood sugars. Would it treat your diabetes? Probably not, but it would certainly help lower your sugars.
Bitter gourd. Okay, apparently it's known as nyanya in Ghana.
There you go. We use it in India, and actually the funny thing in India, in Indian cooking, is we cook it with sugarcane for that very reason. So that's why in India nobody gets low sugar when they have bitter gourd, because we cook it with sugarcane.
I'm just going to share it here. There you go. I don't know if any of our aunties on there, Auntie Amma, if you guys know this one, you can maybe jump in and help us with it, because we clearly don't know what that is. But yeah, okay, fine. I was going to say, just before we go to the question, I was like, you guys are being really shy today. If anybody wants to ask their question in Trio, please do so. We're happy to translate it. But yeah, guys, let's get the Q&A going. If not, then we'll have an early finish today, which is great for me, so I don't mind. But yeah, there we go. We've got some questions on the chat. Yeah, I'm gonna go for the next one.
Fine. So next one from Thelma. I'm having a dry trout when I'm sleeping, and it's making me drink and wake up sometimes 2 to 3 times at night. I'm drinking enough at daytime. What can that be?
Is it a dry throat that they would?
Probably throat.
Yeah, dry throat. Yeah, throat.
Yeah, dry throat. That's a bit of a tricky one. I don't think that's a hydration problem, to be honest with you. That would probably be more for an ENT kind of fellow. That wouldn't represent sort of diabetes. That's probably more air and irritation in your throat when it comes to your breathing. It may also be that you're actually breathing more through your mouth in the nighttime rather than your nose. Your nose has a lot of filters and a lot of hair and causes humidity in the air that you breathe in, whereas your mouth doesn't. So that's probably why. I think Dr. Kos will know some great sports medicine. Any mouth guards or anything you could recommend to help with that breathing at night?
Well, at the moment, I was thinking it could be to do with, like you were saying, throat issues, sleep apnea could be one thing to look out for. So I think the most important thing is if you're having issues with drinking a lot and passing urine a lot, the best thing to do is to see your GP, because obviously then they can do those tests to see if you need, and again, if you're needing any extra support with sort of breathing when you're sleeping, your GP will be the best person to speak to. But I always say this, and I've said this on the show a lot of the time, if you're drinking water at night and then you're waking up at night to go to the toilet, then it's potentially not that you've got an endocrine problem or you've got diabetes, it's the fact that you're actually drinking water and you need to go get rid of that water. So, but if it obviously is connected to something like a drive-through and is really causing issues, then I would say see your GP about that.
Yeah.
Okay, should I go for the next one?
Yeah, sorry, I was blowing my nose. Yep. Next one. So any information on the NHS soups and shakes and diets, please? Can someone without diabetes be on these shakes and soups?
Is that the soups and they mean in terms of the direct trial diet that the trial participants were put on, or is that certain different ones they're thinking about? If it's the one that's from the trial, essentially this is not an NHS trial. This was a funded trial actually, and these were pre-made meals, as it were. So they were pre-made soups and shakes, which were done by the company. So these are not something that you can just buy off the NHS. Essentially, the reason they did that is because it was the easiest way to make sure the participants were on 800 calorie diets, essentially. Obviously, if I said to a participant, you need to stay on 800 calories off, you go and eat, it might be very hard for them to follow exactly 800 calories. And at the same time, they wanted each participant to be on exactly the same amount of food and the type of food that they were eating. So they made pre-made shakes, including things like fiber, fat, protein, carbohydrate. And so that's why every participant was on the same diet, as it were. So that's how they controlled it. These are not things that you could just go to your doctor and say, I want one of those shakes. But what the message is if you really want to try it, I forgot to mention the whole point. There's a reason my dog is just above you on the poster there. Oh, it's just on the side of you guys, actually. So my dog was overweight. I know, shock. The diabetes doctor made his dog overweight. All right. But what we did for him is I did exactly what I preached. We halved the carbohydrates, we increased the protein and fats in his diet, and actually he managed to lose about 10 kilograms of weight. So if he can reduce his body weight by 30% using the evidence we got from direct trial and real life, then certainly most people can.
This sounds like the Cambridge diet. This sounds like the Cambridge diet. Is that like
Cambridge diet was before this, yeah. So Cambridge diet, there's keto diet. So exactly that. That's how they got the inspiration, I think, for the reduced calories. But the hypothesis where nobody asked the question is, can this reverse diabetes? And actually, that's what they found.
Oh wow. Okay. Interesting. Dr. Akos, you were coming in.
I was just saying that's really interesting with the dog, and I was like, I thought he just.
I told you not to edit him out.
I thought you just loved him to bits,
No, he was a part of my trial at home, so that is a real life work. And even the vet was like, I can't believe you guys did this, but we did. So he's a lot healthier now, which is good.
Well, fabulous. We've got another question in here, so I'll read it. Not sure if you've meant. Okay, so is there evidence that genetics in African populations affect how diabetes develops or is treated?
I think there's not set genes that they've sort of located, similar to Asians as well. There's not set genetics that they say, well, this is the gene that's causing it and this is the problem. What we know is more from epidemiology. So what that means is when they study different populations in different countries. And what we also know is actually what's really interesting is when you guys move countries. So when Indians went to Africa and then we went from Africa to the UK. And similarly, if African people go to the UK or the US, it takes a lot less for those patients in terms of a lot less weight gain and a lot less dietary changes to get diabetes. And they also get diabetes at a younger age. You'll even see it in pregnancy. So I know some of us in the audience are through this stage at the moment, but when in the UK, for example, you become pregnant, one of the first questions they ask you is your ethnicity. And if you select you are Asian or you're from Afro-Caribbean community or African community, you will automatically be given a sugar test at 28 weeks during your pregnancy. And that's because our prevalence, even at those younger ages, is higher for diabetes in pregnancy. So we know that this population is affected at a younger age from epidemiology studies around the world.
And somebody's just asking a question about pregnancy. So they're saying if you get gestational diabetes, does that mean that you're going to get diabetes in the future, or you're more likely to?
That's a very good question. Who's been? Yes, you reminded me. I need to submit a paper on this. But yes, so actually, those patients. It doesn't matter your ethnicity, but those patients who do get diabetes in pregnancy, known as gestational diabetes, do have an increased risk of getting type 2 diabetes. So I tell all my patients with gestational diabetes, this is your warning sign. This is a sign that you are more predisposed to getting diabetes later on. Now, I haven't got the figures on the top of my head, but I think the 10-year risk is probably close to 50%, maybe more. So there is a high risk. So one of the things we do in our centers, even in pregnancy, we get you sat down with a dietitian and we try and change your diet early on to then help you. We also ask our GPs, if anyone has had gestational diabetes, they should get checked once a year with a blood test to make sure that they don't develop or start developing diabetes, so we can capture those early and try and reverse it as well.
That's interesting. That so, do we know why that happens? And again, I might be, because you're saying you're writing a paper on it, I'm guessing. But why is it that it then gets triggered by the pregnancy in a way, and then it
So I
doesn't?
think-
Obviously, then it comes back later on. Yeah.
Yeah, I think this is what's been researched at the moment. There's a lot to do with placental medicine and how sort of your insulin is expressed and why you get a surge of insulin resistance. Some people believe it's due to the beta HCG, the surge of that. Some people believe there's actually something we still don't know in terms of the proteins and the placental hormones. And which is why, for example, you're exactly right. If I've got a lady, for example, in diabetes and pregnancy, and she's on 40 units of insulin, as soon as she gives birth, her sugars return straight away to normal within 30 minutes, within an hour. So they no longer suddenly require extra insulin. And so it might be more to do with either the placenta hormones that are being produced. And again, why does it happen in some people and not others? Again, we're not sure. We know there are certain high-risk groups. Age is a factor. So the older you are, the more chance you get of gestational diabetes. If you've had gestational diabetes before or a family history of diabetes, you're more at risk. And of course, your ethnicity as well, which we mentioned. And the last one is your BMI.
I like that question in the chat there. It says, is it because pregnant women tend to eat more?
No, it's one of the papers that we are releasing. I probably shouldn't really talk about it, but we are. It's in review anyway, so it's been submitted. Is looking at actually measuring patients in pregnancy at the booking. Right now, what we do is we wait till 28 weeks. By then, it's probably too late. So we're actually trying to introduce in the NICE guidelines in the UK to try and start screening after 8 weeks of pregnancy. So this is not something that the women are doing. This is probably something that's more hormonal that we still don't understand.
And what about the babies? As a question in the chat.
The babies will have a problem because if you've got higher sugar in your blood, you'll get bigger babies. So we have something called large for gestational age. And if you've got a bigger baby, you might have more complications when you deliver. Problems such as shoulder dystocia, where your shoulder sort of gets caught when you're delivering, or even preterm deliveries as well. So they're usually the risks of gestational diabetes. Most centres in the UK will advocate to deliver at 38 weeks rather than waiting till 40 weeks for gestational diabetes. We are trying to, in our centre, treat them earlier and try and now get more closer to term as possible. So things are changing in that. I think it's a really important point you guys mentioned, because gestational diabetes has fallen behind. So maternal care and diabetes has fallen a lot more behind compared to type 2 diabetes. And you can see it from the range of medications available to those patients compared to those who are pregnant. So, yeah, it's certainly a big area. And I think it's one of the areas the government has highlighted in their 10-year plan to try and improve.
Okay, last question. I think in terms of what about the babies, I think another thing she was probably trying to ask, I'm thinking, Auntie Liz, correct me if I'm wrong, but I think she's talking about what about the babies in the future? Because obviously we talked about how the pregnant ladies will definitely get diabetes in the future. Does this affect the babies at all in the future and their risk of getting it?
Yeah, I think it does. We know this because when we speak to our patients, they'll often say, my mum had gestational diabetes when she was pregnant. So we know there is a higher risk. Already having that higher risk of diabetes in your family will affect you long term. Why it happens, I think at the moment the preliminary data is showing that in those babies there's actually less protein mass and more fat mass. So they're actually born with a lot more fat. And if you remember what we talked about in the talk, it doesn't necessarily mean you're overweight fat. It could also be fat around your organs and things like that as well. So later on in life, yes, these children will be at higher risk of diabetes. But again, that would also be the same case if you had a family history of diabetes as well.
Fab. Sorry, my nose. Last question from me. So, some people sort of don't take insulin because they feel like it's dangerous. So, what would you say to that?
Insulin is actually one of our safest medications I can give. any patient. And that might sound very, very strange. But the reason is because you naturally produce it. So you're going to have less side effects. I think where the fear with insulin comes is when you're not dosed properly, or you take too much and you go low. And that's where people feel unwell and people panic. So I think in terms of side effect profile, it's very, very low because it's a natural thing we're giving to you, which your body already produces. There's also actually, when you think about it, a lot of fear, because when you first see someone, and you can ask anyone who's ever been diagnosed with diabetes, what's the motivation that the healthcare professional gives you to make sure you change your life? They'll always say, well, if you don't take your tablets and you don't change things, you're going to need insulin. Now already the patient's got in their mind, oh my God, that is something I do not want and I never want. So already, before you've even started, you've instilled fear into the patient. And the way I see it best is in our pregnant patients, because they're carrying baby. They're obviously a lot concerned for their young one. And as soon as I say I need to give insulin because it's going to help the baby as well, usually most patients are on board straight away. And they say, yeah, no problem. Just teach me how to do it and I'll do it. The other good thing is remember nowadays now we have better monitoring. Things you can wear on your arm, things that go directly to your phone, and you just swipe your phone onto the sensor and that's it. It measures your sugar. It sets alarms and wakes you up if it goes too low. So we have more technology now that's coming out and making insulin even safer. So I think that will probably change as the future goes on as well.
Yeah, I think from that point, even from a doctor point of view, and we had like a little conference, a GP conference, and then somebody from diabetes came to talk to us and was like, don't be scared of insulin, because even with the GPs, like we don't tend to you know, and I don't think we can actually start insulin at the GP. I think it has to be started by a specialist, doesn't it? And we kind of continue it. I can't remember how that.
No, I think it just depends on the type. Some GPs do in our local area. It depends, and some will just send us a message saying, "Can I start it?"
Yeah, but I think a lot of GPs actually avoid it or will not start it without getting advice from a specialist. And I think that also, like you say, puts a bit of tension on it, because then you almost think like, oh, this is a specialized drug, you know, I have to be monitored by a specialist. Like even the GP is a bit apprehensive. So I think it probably even has to start from the doctors ourselves. I think we're even made, I don't know, in the past we've been made to be scared of insulin, that we've almost kind of portrayed that onto the patient as well.
Absolutely. And I think, you know what, if you said that to an old school GP, they would say rubbish. Right? If you say to a new school GP, there's a lot more fear, right? And is that maybe because healthcare is changing, that we have a diabetes specialist nurse that comes to a practice and sorts all that out, so we don't see it as much? Same that we don't see the heart failure as much because we have heart failure nurses and asthma nurses. So actually that might just be this changing sculpture of actually in every practice we have a diabetes specialist nurse. And that's probably what's changing there.
Yeah. Oh, Auntie Liz, you always do this. We're just going to go off.
That's fine. That's fine.
Auntie Liz, please go on.
Thank you, Doctor. Thank you, Dr. Sunjay. A quick one.
Mm-hmm.
I'm a bit confused because I don't know much, but I thought insulin is for type 1 diabetes and all the other tablets for type 2.
Ooh.
So when are they giving insulin and when is... So that's a bit I'm confused about. Thank you. Thank you very much.
No problem. So that is the old myth. Okay. So what used to happen even in the UK, even, GPs and diabetes specialists used to say this: if you're on insulin, you're type 1. If you're not on insulin, you're type 2. Okay? That is all completely wrong. Okay? And the reason being is what used to happen back in the day is if you were very sick with diabetes, they automatically put you on insulin. That does not mean this patient actually required pure insulin. They could have actually required tablets. It's just we didn't have the testing at the time. In fact, so much so that you might even still see it in people's notes today. They will also be termed insulin-dependent diabetes. That is not the same as type 1. Type 1 diabetes is an autoimmune condition where your own body attacks your pancreas and causes you to produce no insulin whatsoever. So these patients are insulin deplete. They are not insulin resistant, they are insulin deplete, meaning if I measure their blood, they have no insulin in their blood. In type 2 diabetes, they are still able to produce insulin, but there is a lot of resistance. So they require more insulin to get the required effect of lowering their blood sugars. So that's the main difference. A type 1 diabetes patient, if you withheld their insulin, they would be very unwell and they would probably die because of the lack of insulin. They would go into what we call ketoacidosis. In a type 2 patient, they would just present to you with high sugars. They would not necessarily become acidotic in their blood, and they would not prevent sort of life-threatening, but they would have very poor controlled sugars.
Hope that answers your question, Auntie Liz.
Yes, very much. Now I can explain it better to my students.
No problem.
Thank you.
Thank you, Auntie Liz. Thank you, doctors. Thank you, Dr. Sunjay, for your time and speaking to us about something that's so important in our communities. And just before we release you or let you go, if you can just give us like few words, lines of wisdom that we can take away with us.
Almost like a summary of,
What I would say, the most important thing is don't always think about the sugar. That's number one. Think more about the carbohydrates and a balanced meal. And when you see a relative going for the sugar, okay, and the non-sugar tea, but they're having a nice deep fried snack with their sugar, please remind them this is what causes diabetes, okay? Not the fact that they just didn't have 1 cube of sugar in their tea. And don't forget to ask your relatives, has anybody checked your eyes? Has anybody checked your blood pressure? Has anybody checked your cholesterol? Nobody will ask people with diabetes these questions, which will make a big difference to their lives. So think about the person as a whole. Don't just think about the sugar. That's my main message.
Thank you so much. And pizza's green. Yay. Dr. Kos, anything else you'd like to add?
Oh, gosh. No. I think you said it all. Honestly, thank you so much for coming on the show. I think we'll probably have you back another time because people really enjoyed it and I'm getting really good comments in the chat. So,
No problem. Anytime.
Yeah. There is one more question. Can people who are not diabetic try the trial menu?
Yes. So any if you think about, I think somebody mentioned the Cambridge diet earlier. So all of these diets, keto diets, they were made for people. This is because the trial was just done to see, can weight loss reverse diabetes? That was the main aim. They didn't know if it did, but what they found is that yes, it can help remit diabetes. So think about yourself. If you're not diabetic, but you think, you know what, for my BMI is quite high, I've got a high family history, I want to try and lose even 10 to 15% of body fat, you can do any of these trials in terms of diet. What I would say is if anyone is doing a diet, please make sure that it is, as a whole, a balanced diet. You need a little bit of fat, you need protein, you need fiber, and you do need a little bit of carbohydrate. This is not to go completely without anything. But what you can do is reduce your calories. So, for example, if you took a week's worth of what you normally eat, let's say it was 2,000 calories, what you can do is for the next few weeks, try 1,500 calories. Then start seeing if you lose weight. If you don't start losing weight, decrease it by 200 calories almost every 2 weeks until you start seeing you're losing weight. Remember, everybody has a different metabolic rate, and that's why it might take different people different amount of calories to either gain or lose weight.
I think I know you're loving this, aren't you? Because you're like...
So I was going to say, as somebody who actually did the Cambridge diet, I was just going to say that be mindful of it, because what happened was it's very good in terms of you will lose the weight because, it's structured. You have, what you're eating. But then when you do leave it, when you do stop and then you start to eat normal foods, it becomes an issue because the portions, you don't understand it. It's the transition. So I put on almost all the weight I lost again. And then I tried recently, I tried the OMA diet, and I, like you said, I had cheat days. I ate normally, I ate the normal foods, rice and everything, and I dropped about 8 kg in 8 weeks.
Wow.
So yeah, that's the only thing I would say. Definitely the diet is good. You can try it, but just make sure that when you do start having eaten your normal foods, just make sure that you are very strict on your calories, and if not, you're going to
Yeah.
add weight back.
Absolutely, and that's probably what you notice as well with these different diets is actually you reached a calorie threshold where you were under your metabolic rate. And what probably happens when you went back to your original diet, you went above that threshold and started gaining weight. So that tells you internally what my metabolic rate is. And at least you can explain why you then gained that weight or lost that weight.
Yeah, brilliant. I'm gonna let Sanjay go because I only told him that he'll be here till 9, but he's
That's okay.
Some extra minutes. So thank you so much. AK, I'll come to answer your question in a minute because that's not particularly a diabetic question. But yeah, no, thank you so much for being here. As I said, I think we'd love to have you back. So we'll chat
Anytime.
about that background. But yeah, thanks for being here. We really appreciate your time.
No problem. Thanks for the invite. Take care, guys.
All right, take care.
Thank you.
Just before I do the round off in terms of what's coming up in the weeks, obviously, you know that on Thursdays we have a time at Taptap Send. On Fridays we have Talks to the Lawyer. Same link, same time. So make sure you to join. I'm just answered the question about AK in the last. It says, can I request a kidney test if I don't have diabetes? Yes, you can. Some GPs might do the test, some GPs might not, because sometimes they say, why do you need a kidney test? Is there a problem? So unless you some GPs will literally say unless you're having symptoms that require a kidney test, they won't do a kidney blood test for you. In the same way that diabetes is not diagnosed through a kidney test anyway. So if you're worried about diabetes, it's not a kidney test that I'll be doing. If you've already got diabetes and you're worried about your kidneys, then that's a different thing. So I guess the answer is yes, you can have a kidney test if you don't have diabetes, but the caveat to that is why do you need a kidney test? It won't just be done just because you request for it. There has to be a reason for it. Because it is NHS is a free service. So if you're paying for your own kidney, if you go somewhere you're paying for your own kidney test and nobody cares. You can just say, can I have a kidney test? You pay for it, you get the results. But if you go to the NHS, it's like we have to justify why we do stuff. So if my patient comes to me and be like, doctor, can I just have a kidney test? I'm going to be like, well, why do you need it? Because I need to justify it when I request a test. So I hope that answers your question. Auntie Liz, your hands is up.
Yes, Dr. Akos and Dr. Abna, I'm sorry that you're sneezing and coughing. I wish you speedy recovery. This has been, I don't know, your ginger, well, that's not why my hand is up. Dr. Sanjay mentioned something about, and we all know that insulin is produced by the pancreas or something like that. So do they do a test for blood test to check your pancreas or they don't? So how will somebody know that you're producing enough or you are not producing enough, or how do they find out your pancreas health? That's the question.
Well, we kind of don't. So we don't need to test your pancreas to know in terms of how much insulin you're producing. All we need to do is test your sugar, because if you're producing enough insulin, then your sugar level should be able to. I left my card upstairs, but we have so for example, there's a glucose tolerance test, which you do. We give you like an orange juice. You wait 2 hours. We take your blood before your blood sugar before the orange juice. You take your orange juice, we let you wait for 2 hours, and then we take the blood sugar again, and then we check within the 2 hours how much sugar you have in your blood. So that's going to let us know if your pancreas is working and you're producing enough insulin, your sugar should have gone down by the 2 hours. If you don't have enough insulin, your sugar will remain high. So that tells us, is your pancreas working? We don't necessarily need to test your pancreas for us to know that your pancreas is not working. It's the same way, it's almost in a way like saying when you have a car, do you always need to go and check the engine before you know that the engine is working or not? No, if I turn the car on and the car is not working, then I know there's something wrong with the engine in a way. So yeah, beg your pardon. That's how we test for the insulin. In terms of people with type 1 diabetes, even with that, it's not particularly the pancreas that they check. They check for autoimmune markers to say, okay, do we have these markers going against the pancreas? So we don't need to check the pancreas itself, but there are other ways in which we can test if the pancreas is working or doing what it has to do. Even in the same way, like in the kidney test, if you test in kidneys, the results we get for the kidneys is things like we're checking your sodium levels, your potassium levels, and we're checking your urine levels when we do your sodium blood test. So essentially, we're not actually checking the kidney itself. We're checking the things that the kidney is supposed to clear. And if your kidney is not clearing enough of your potassium, your sodium, your creatinine, and your urea, we do a creatinine and urea calculation. We say, okay, so this is your creatinine clearance. And then we say, okay, because your kidney is not clearing your creatinine enough, that means your kidney's not working as it should be. So that's how we test. I don't know if that makes sense. We don't test for the actual organ. We test for the function of the organ, and then we can tell whether it's working well or it's not working well.
Thank you. I know you are not feeling well. You want to go and sleep. So
Oh, no, that's okay.
Because somebody mentioned something that like they're scared of the pancreas, something or the other. And if doctors are not checking, how would they know if the pancreas is not working? And yes, I think the person got cancer of the pancreas, and they said it's the deadly one because it's very, well, by the time they realize it will be far gone.
I think that I said that.
Oh, you
did?
Yes, that's it. Here is where I learned my medical lessons, you know. Yeah, thank you.
Yeah, I remember saying that as I think the cancer I'm scared of the most is pancreatic cancer, because before you find out, then it's pretty much too late. But that's the thing, we don't really have a way to check the pancreas. Like I said, the pancreas has a lot of functions, insulin being one of them, and insulin maybe being the most checked one of those. But essentially, if we're worried about diabetes, like I said, we check the sugars. If we're worried about a pancreas, we'll do a CT scan, or we'll do some type of imaging, like an MRI scan. The only way to diagnose a pancreatic cancer will be through a scan, essentially. Yes, there are some markers that can help as well, and yes, we can check other functions of the pancreas. But like, as I say, it's not something that we do on a general basis, and it's not like a very common cancer as well. So we don't tend to check for it unless if we've got high suspicion for it. So yeah, I see where you're coming from, Auntie Emma, with regards to having to check the pancreas, but there's not enough evidence, I guess, to justify doing that in every case.
This is not Auntie Emma, but thank you.
Oh, sorry, Auntie Liz, gosh. See, I miss her. I know she's in Ghana and I miss her. That's what it is. Somebody tell her I miss her.
Well, she was on earlier. I don't know if
was she? I didn't see her.
Yeah. We all miss her. But thank you very much. And thanks for the education you always give us.
No problem.
What?
Sure,
hands up. So why is it that you guys weren't asking the questions when doctor was here? Oh, Victoria. Oh, she put her hands up. You can come. Where is she? Victoria?
She's gone. You can ask your question.
Ask your question, Victoria. Don't worry about it.
Oh, there she is. No, unmute yourself and then ask it. Yeah.
Oh, sorry. Mepa show mama question now will be sign a comma make a crantina me person tentem nam pese me bisano about the creatinine no cho no betimi achire mu kakra what then okay so what like BBT say creatinine.
No, so I was given an example. For example, you check your kidneys you check your creatinine clearance. That's what lets us know if your kidneys are working or is not working. So it wasn't, she was talking about pancreas, but I was just using the kidneys as an example to say even with the kidneys, no, and yes, you check it. The kidney itself, like we don't go and take a biopsy of the kidney or go and scan the kidney. We just check so creatinine is a protein that your kidney basically clears from the body. And depending on the rate at which it's clearing that, we check that. We do a bit of calculation with your urea, with your sodium, with your potassium, and then we check, okay, how much volume is your kidney clearing? How is this normal? And then we say, okay, because of that, your kidney is working at 60%, 40%, 20%, or whatever. So it's not, the creatinine itself is not something that you should be worried about. We use it in relation to checking the health of the kidney.
Oh, I see. Thank you very much.
No problem. Okay, I think that's our last question.
Yes, thank you, everyone. If I just say yes, Dr. Akos, please take it from here.
Yeah, I think so. We've already closed anyway, but yeah, just say thank you all for coming on. Honestly, today I think we had a good show. I think we were a little bit shy. We didn't ask so many questions, but that's fine. I think we had a lot of questions coming through the chat as opposed to having the hands up. But thank you all who participated. We hope to see you all next week. So we're back on track every Wednesday, 8 p.m. So every Wednesday, OT Health Talk. Every Thursday, Time with Taptap Send. Every Friday, Ask the Lawyers. We've also got our program coming on, which is let me get the flyer up so I can share it. So we've got the what is it even called? The health screening program, which is happening in Coventry, is our first live program. So as you can see there, it's early detection in women. Is to commemorate sort of almost Women's Month, which is March. So on 21st of March, we're having a health screening where we're going to have some speakers, we're going to have a panel talk, and then we're also going to be checking blood pressure, blood glucose, and we're going to do menopause and mental health screening there as well. So please take down the flyer details. We've been putting them on OT Media as well. Make sure that you come along to that. Is there anything else? I don't think so. But all information will be shared on OT Media platform. But thank you all so much for coming. We really appreciate your time and hope you have a good week and see you next week.
Thank you.
Thank you and good night.
Good night.
Good night.
Good evening.
Bye-bye.
Hey, Uncle Patrick, good evening. I hope you're
Dr.
doing well.
Akos, I miss you a lot. I've been out for a while. Greetings from Canada.
Greetings. I'm here now. Lovely to have you.
How is the snow?
Oh, now the weather is warm. We are in about 10. Oops.
Oh, thank God. Anyway, we wish you all the best.
And hope to see you all next week. I look forward to spending more time with you. I'm now back, so yeah. See you more often now.
Yeah, where is Dr. Kojo? Dr. Mustafa was on, I think.
Yeah, Dr. Kojo, he said these days he's working not like night shifts a lot, so it's going to really be difficult to get him on the show. Yeah, his schedule's
getting more money, eh?
But we'll have him. I think we'll have him one of these days because of the Women's Month. So we've secured him for one of the shows. So he'll be coming on soon.
Okay, and Dr. Blessing and
Dr. Blessing is on next week, so.
Oh, good. And Dr. Mustafa is coming on when?
The week after that.
Hey. Okay, we are going to have a good time. God bless you all.
All right, God bless you. Good night. Bye-bye.
Good night. Bye.